So we have a 59-year-old man and he has a 40-year pack year of smoking, and he had been brought to the emergency with altered mental status. He had a nagging cough and for last several months and occasional dizziness earlier this week, and is increasingly confused. Today doesn't make any sense at all. That means he's almost semi-conscious. But as far as examination concerned, CNS is normal, cardiovascular and chest examination all are normal. Well, if you look into lab reports, sodium is reduced, potassium is normal, BUN creatine normal range, calcium is and glucose are all in the normal range. Plasma osmolality is definitely much reduced. Urine osmolality is very high. Plasma osmolality is reduced and urine drug screen is negative. So basically you are getting, main thing is hyponatremia with reduced serum osmolality and increased serum osmolality. This is the nutshell that we can talk about. Now chest X-ray reveals a mass in the right lung and likely finding that we expect. This is normal extracellular fluid volume. Why this answer? Why not others? Let's learn the basic concept. So in this patient, normal extracellular fluid volume occurs because this patient has SIADH, syndrome of inappropriate secretion of ADH. But why it is happened? Maybe that the patient has small cell lung cancer. Why we can say SIADH? Because the lab finding of hyponatremia, reduce serum osmolality and increase urine osmolality, they are the classical finding that we get SIADH. But why you are thinking about small cell lung cancer? Because in this SIADH can occur. Now, what are the points which favor the patient in this phase that he got small cell lung cancer and causing SIADH? His 40 years smoking. We are well aware that small cell lung cancer is a well-known problem due to smoking. Nagging cough last few months only. Dizziness and confusion. Chest X-ray revealed a mass and sodium level is reduced. That could be the explanation of why he is getting dizziness and confused. We are well aware that hyponatremia lead to altered sensorium. One more thing I like to add to your knowledge, that sodium, typically sodium problem, it lead to more of the brain problem. But potassium may be high or low, that lead to cardiac problem. It's a very basic thing, but I just refresh your knowledge that sodium doesn't have much on the cardiac effect, more of the brain effect. With this background, so normal serum sodium is about 135 to 145 millimole per liter or even milliequivalent per liter, both are same because valency of sodium is 1. Now let me tell you what happened, why hyponatremia occurred. You got to understand some basic concept. For that, I have got one glass, okay, it has 100 ml of water each, and I add 100 milligram of salt in each. It means each glass has 1 milligram per ml, the concentration. Now if I add 100 ml water more in this glass, volume become 200 ml, but the salt is still 100 milligram. The concentration of the salt will be 0.5 milligram per ml. That means sodium concentration has gone down. It's not due to sodium problem, but excess of water. Okay, so it is extra amount of water which lead to reduced sodium concentration. Now let's correlate this with what is happening with SIADH. This is the nephron, and we are all well aware that we have ADH. We are also aware that it absorbs only pure water, it absorbs free water, what we write as FH2O. It only absorbs water, it doesn't absorb any sodium or like potassium. And it tried to maintain the plasma osmolality between 280 to 300. When the osmolality goes to 300, when the body is dehydrated, extra amount of ADH will try to absorb as much as water possible. But when this reaches somewhere around 280, the ADH level goes down. And that means more and more urine will go out. This is how we try to maintain the plasma osmolality to 280 to 300. This is a basic. Now in SiADH, although the osmolality has gone to 280, now we don't want extra water, but still body keep on secreting ADH. ADH will keep on absorbing water and plasma osmolality will go down further. And that means that plasma is getting diluted, and this is how hyponatremia will happen. Okay, so this is a basic reason, but with this explanation, plasma volume has increased, and that lead to low sodium. It is exactly what I gave you example of the glass with 200 ml of water is there with 100 milligram of salt is there. But in the answer I said the extracellular volume is normal, or you can say it is euvolumia. But in this we are getting hypervolumia. How can we explain like this? There is something more happen. More happen is that we go back to basic. We are also well aware that in the DCT and the collecting tubule, aldosterone is there. And it tends to absorb water, sodium and water. Okay, and sodium water is absorbed by the effect of aldosterone. So now when the plasma volume has increased like this, body will secrete less amount of aldosterone, less amount of renin. So now renin and aldosterone both are reduced. That will lead to extra loss of sodium plus water. Already the body is diluted, less amount of sodium is there. Now both sodium and water equal amount will go out. With the result, it will lead to what? Hyponatremia will persist, but the volume become euvolumia or normal extracellular volume, because extra salt and water has gone down. So this is how the reason why hyponatremia is there and hypovolumia is there, right? So again, same glass, 200 ml of water, 100 milligram of salt, the concentration 0.5. Now in this, I remove 100 ml of water. Remember, salt is dissolved in the water. Now I remove 100 ml. Now 100 ml of solution is left. But it has now, definitely, it has got 50 milligram of salt. The concentration is still 0.5. Volume has come back to 100. Okay, so this is euvolumia and hyponatremia. I hope now you are very clear about it, and believe me, this point is not clear. To 90% of students are not clear about this point, how euvolemia occurs in SiADH. So either euvolemia or maybe slightly hypervolemia, but by and large, euvolemia is a better option. So friends, so same story now in a depicted way. Increase ADH, increase water absorption in tubule, that lead to expanded plasma volume, which I mentioned to you, and that lead to decrease renin, decrease aldosterone, natriuresis occurs, and finally the net result is low sodium, serum sodium, low plasma osmolality, no edema and no hypertension. This is the net result. So remember, there is no edema, no hypertension in SiADH. Well, now if you look into other option, now your basic concepts are very clear. Option A is incorrect. Maximum dilute urine. No, it is urine is very high because whole water has been reabsorbed. So urine is concentrated, and in our case, plasma osmolality is 360, much more than the normal. JVP will be raised, no, because no CHF, JVP not raised, because CVS examination is normal. even chest examination normal. So there is no chance that no crackle because chest examination is normal. It is written in the question also CVS, CNS examination normal and no edema feet because CVS examination normal. And moreover, I already gave explanation to you that sodium and water is lost, so no edema feet is there. Now, there are two important conditions where edema feet doesn't happen. One is SIADH. Now, question, write down the answer. Tell me any other condition you know of where electrolyte imbalance occur, but no edema feet occurs. I repeat the question. Tell me any other condition you know of where electrolyte imbalance occur, but no edema feet. Well, the answer is Cone syndrome. There are two conditions where edema feet is not a feature. So, golden line to remember in SIADI there is euvolumia and hyponatremia. We have a 55-year-old man. He comes to the general physician with cough and breathlessness. 2 weeks, short history. And before this, he was fit and well and was not any medication. That means whatever has happened only in the last 2 weeks, he is a known smoker of 10 cigarettes per day for 25 years, fairly large history. And now he has thirst, polyuria, generalized muscle weakness, all in the last 2 weeks only. BP is elevated and there is ankle edema is there. So now when investigations are done, he has hyperglycemia and it is 300 milligram. As far as sodium is concerned, it's normal, but on the upper side of normal. This is hypokalemia and this is metabolic alkalosis is there. So that means these are the three main abnormalities that we are getting in this particular patient. Most likely diagnosis is ectopic ACTH secretion. Well, now patient has cough, breathlessness for last 2 weeks only, short history. But he's a smoker for last 25 years, 10 cigarettes per day, long history of smoking. So the suspicion here is that this patient has small cell lung cancer, also known as oat cell lung cancer. But now, before I proceed further, I must emphasize on one point. Although there is 2 week history of coughing and expectoration, of course, 2 week history is too short to diagnose any case of cancer, especially in case of smoker. But when I say why we are thinking about small cell lung cancer, keeping this question in the mind and keeping in mind the other options also. So this point should be very, very clear to you. Otherwise, 2 week history, nobody can diagnose about cancer unless there are special features which are there in this case. That's why I said we have to be focused on keeping in other option also. Now this tumor is a very rapidly growing aggressive tumor characterized by very early metastasis to other sites. Since it is a distant spread is there, that's why we never do. Surgery is not the treatment of this choice at all. In contrast to small cell lung cancer, which is confined to one area, surgery, the first line treatment here, surgery is never done because the disease is already disseminated. Well, one more feature of this is the range of paraneoplastic syndrome that occur due to production of various hormones, and the common are ACTH and ADH. And this ACTH, which is so-called ectopic secretion of ACTH, it produces picture like Cushing syndrome. And ADH will create picture like SIADH, syndrome of inappropriate secretion of ADH, which lead to hyponatremia. Okay. Well, so at the moment we are talking about ACTH, ectopic secretion of ACTH, which is the option also in this question. Now, one more thing. I did mention to you that ACTH secretion is there, but still the typical feature of Cushing syndrome are absent. Okay. Like if I asked you what are the Cushing-like feature, Cushionoid, moon-like face, obese, hirsutism, etc. These are not because it is a cancer also, and rather it lead to weight loss. So doesn't have a buffalo hump, and all these things are not the feature. Well, now these patients may present with weight loss, pigmentation, hyperglycemia, okay, then hypokalemia, low serum potassium level, and metabolic alkalosis. In fact, there is a profound hypokalemia is there because the amount of ACTH is very, very high. So that lead to profound metabolic alkalosis and hypokalemia. And of course, there is increased serum and urine cortisol concentration will be there, all due to increased ACTH. Now, let's look into other option. Can we think about Cushing disease? Well, so Cushing disease is a type of Cushing syndrome. Which is due to pituitary adenoma. Right? So, ectopic secretion of ACTH is like a Cushing syndrome, but that is not a Cushing disease. But Cushing disease has a feature of Cushing syndrome, plus there are feature of pituitary adenoma also. So now, prior to onset of this symptom, he was fit and well and was not on any medication. Well, if you are thinking about Cushing syndrome, which is due to pituitary adenoma, in such cases, they usually have headache and they usually may have some vision disturbance. But there is no history of headache, no vision disturbance, so it is ruled out. Moreover, we are getting patient with smoker with the respiratory system symptom. Diagnosis goes more in favor of ectopic secretion of ACTH. Okay. Now, I have a question for you. Write down the answer. I mentioned to you that in case of pituitary adenoma, patient may have vision disturbance. Write down the answer in your copy. What type of vision disturbance you can expect in these patients? Well, the answer is bitemporal hemianopia. This is due to pressure on the optic chiasma. Option C is incorrect, that is dermatomyositis. This usually associated with proximal myopathy. Now, one thing I must clarify, proximal myopathy can occur in this patient also having ectopic secretion of ACTH, as well as in Cushing syndrome also proximal myopathy can occur. But in case of ectopic secretion or Cushing syndrome also there is metabolic alkalosis and raised sugar, and there is hypokalemia is there. These are findings that we get in these patients. But these findings are not. That means hypokalemia, metabolic alkalosis, and raised blood sugar, they're usually not the feature of dermatomyositis. Moreover, they may have many other skin signs, okay, like heliotropic rash, etc. are there. So this is not the case. Option D is incorrect. Primary hyperaldosteronism, although BP is high in this patient, but increased blood sugar, hyperglycemia, what we have seen in this case, in the question, this is not a feature of primary hyperaldosteronism. That goes more in favor of increased ACTH. Moreover, cup baths are not feature of primary hyperaldosteronism. Okay, and moreover, elevated cortisol are there, and in case of primary hyperaldosteronism, so-called Cone syndrome, aldosterone level are raised, cortisol level are not increased. Adrenal deficiency, which is so-called Addison disease, is consistent with hypoglycemia. Hyperglycemia is not a feature, hypotension, but in our case, and moreover, hyperkalemia occurs in Addison disease. But in our case, we have a hypokalemia, hypertension is there, they are not the feature of Addison disease. So this also option ruled out. So golden line to remember, small cell carcinoma of lung secrete ectopic ACTH, and which can lead to Cushing syndrome. Well, I hope you liked the session. Just to inform you, we have following courses for you. Smart Medicine, there are 350 hours of pre-recorded video lecture of whole internal medicine. It includes all super specialty and allied subject, covering A to Z, including basic concept about every topic. Second, we have tests and discussion. There are more than 1,000 questions with discussion of the questions, sample question and discussion you saw in this session. Now, third thing is Medicine Simplified, which is a textbook of medicine. Harrison is the ultimate book to read medicine, but it is too vast. Reading one page of Harrison, you need half an hour. To understand, you need 2 hours, but you need only 2 minutes to forget what was written in that page. Then what is the solution? We have Medicine Simplified. It's a textbook of medicine, but so-called mini Harrison. It's a summary of what you need to read from Harrison. The book is available in Amazon also. Now, these 3 things are more than enough for your MD, DNB Medicine and Family Medicine final exam preparation, NEET SS exam preparation. You don't need to read any other book. These 3 are complete in all the aspects. For more detail, you can contact at this number. It's a for mobile as well as WhatsApp. And this is my personal email ID. Anybody want to reach to me, you can contact me at this email ID. Thank you very much.